Okay, so I'm going to talk about disitamab vedotin and some of the data that's been presented. These are my disclosures. And so looking at HER2 expression, and Dr. O'Donnell's shown some of this data. This is data that was presented by Dave Hagan from Memorial Sloan Kettering, demonstrating HER2 2 plus 3 plus expression by immunohistochemistry in urothelial carcinoma of over 50%. And I think it's important for those who may not have followed the story as closely that HER2 is not a new target in urothelial carcinoma. In fact, there was work done in the past looking at HER2 expression. There are actually clinical trials that were performed. Most notably, Dr. Maha Hussein performed a trial that actually Dr. Petrolak was involved in, and I was involved in at Cornell with Dr. David Nanas, combining paclitaxel, gemcitabine, and carboplatin with trastuzumab. And then I also participated in another study that Dr. O'Donnell ran of afitinib in patients with HER2 overexpression. And so again, not a new story, but new agents. And so this is disitamab vedotin. Disitamab vedotin is an antibody-drug conjugate. It is conjugated to the toxin that you've heard about, monomethyl auristatin E. And there's been some data presented in several abstracts and subsequent publications. And so this is data out of China where we first saw disitamab vedotin appear in HER2 2 plus, 3 plus, and 1 plus, all demonstrating activity. And so if you look at the HER2 2 plus, 3 plus, you can see response rates of about 50%. And those responses were seen in patients with visceral metastatic disease. And you can see promising progression-free and overall survival data. There was peripheral neuropathy, as one would expect. And then even in her 1 plus patient, there were also responses, upwards of about 25 or so percent. What about the combination of disitamab vedotin with immune checkpoint inhibition? So this is the first experience that was presented with toripalimab, again, out of investigators in China. This is a PD-1 inhibitor. Here, combining this drug, which was previously referred to as RC48, with toripalimab, response in 72% of patients. And the updated overall response data is 75%, duration of response 8.6 months, PFS 9.3 months, and overall survival over 30 months. And so, again, I think certainly promising activity that's been seen. And there's been a lot of discussion about what are the best antibody drug conjugates to combine with immune checkpoint inhibition. And Dr. Galsky and others have had some nice presentations suggesting that there may be something about monomethyl auristatin E that appears to generate higher improvements in response and outcomes when combined with immune checkpoint blockade. This is data that was just presented at ESMO by Dr. Galsky. This is the cohort C of the RC48G001 study. So this is in the first-line setting. This was the safety run-in portion for this study. This study looking at the combination of disitamab vedotin with the PD-1 agent pembrolizumab. The part 2 is going to randomize patients to disitamab vedotin alone compared with disitamab vedotin and pembrolizumab. And so in this safety run-in, you can see that actually the majority of patients were HER2 low. That is 70%, 75% had visceral metastatic disease, and 20% with liver metastases. And the median follow-up was relatively short. But the response rate, again, I think pretty exciting at 75% with a 35% complete response rate. You can see the plots on the side. The duration of response was not reached. But I think, again, this is certainly a promising combination, very similar to the sort of activity that we saw when it was combined with the other PD-1 agent with the data out of China. And so I'm going to be able to end this talk early because that is sort of the summary of the data. This is the ongoing phase 3 study of disitamab vedotin and pembrolizumab as compared to chemotherapy in the first-line setting in HER2 overexpressing tumors from patients. This is comparing DV pembro to platinum-based chemotherapy with dual primary endpoints of PFS by BICR and overall survival. And I think, of course, this question has come up before based on the results of EV302. Is this still a reasonable comparator? There was discussions of this within the renal cell cancer session as well. And these are, again, good things for patients in the rapid development of therapies, but sort of the challenges that arise in the context of rapid drug development. And with that, I'll end. Thank you.